Thank you, Jen, for introductions, and Sereni, you have given a very amazing talks, and it overlaps with my talks, and it helps a lot later on when I try to explain certain points. So I always start with this table whenever I give a talk on epilepsy management to a general population, general physicians, and even medical students, or in those doctors in primary care medicines, partly because there is a trend of shifting the care of medicines from primary care to neurology. In the past, when I was a houseman, when I was asked to go and see patients or help up in a very busy clinic, I have even a chance to see epilepsy patients, but now houseman has no more opportunity to see patient in the clinic. Then later on, the MO will be in charge taking care of epilepsy patient, and subsequently the physicians, and then later on the neurologists. And now there is even a certain subspecialty called epileptologists who are specialized in epilepsy care. So when we ask about, ask my friend in GP, in general clinic, many of them has not have any experience or much experience on taking care of seizure and epilepsy, which I think we need to shift on in the plan for epilepsy management. So this is the one that I suggested to my primary care team. Try your best to start off with making a diagnosis, understanding them in terms of semiology, as what Dr. Koo has mentioned, determine whether they are seizure or not, as what Prof. Raymond stated, and then go on to the investigations as necessary by Prof. and other Dr. Raymond Tan, and then only talking about management and perhaps start the initial management before refer to the neurology team. This is the consensus guideline, and there is a participant asking about where it is. This is in www.neuro.org.my, and then you click on the resources, and then you click on the consensus guideline, and you will see the guidelines, and it's downloadable in PDF format. As I usually started management or talks on seizures going through this list, but today I'm not going to talk about this, partly because it was covered previously, and I'm only going to emphasize or focus on this map or principle of management. However, I'll only talk mostly on first seizures, and second, choosing the correct first line antiepileptic drugs, rather than going on to the others, partly because this is for general pool. So let's start with the first case. So this is a patient, 30 years old man with first generalized tonic-clonic seizure, no focal deficits and clinical examination, scan normal, biochemistry, blood screening or normal, EEG normal. Do you want to start AED? Can I have the pool for case number 1? Yes. So do you want to start AED? Wait, no, wait first or start immediately? Okay, can I have the pool results? Can I have the pool results? Oh, thank you. Wow, many people will say wait, and 5% will say start straight away. So in fact, this is what I usually do as well. I'll talk to the patient, give them both the options, and let them choose, but most of them will choose to wait. So what will happen is that for first seizure, half will not have recurrence, and that's why if you start treatment for 2 years and patient may not have recurrence, which means the patient has to take 2 years medication for no reasons. And secondly, the immediate treatment will not improve long-term remission rate. So even you start later on, the overall outcome and quality of life are still the same. So, however, there are certain conditions that we will consider starting treatment even when patient have first seizures, especially if there is a scan lesion in the CT brain, if there is abnormal EEG, especially the one shown by the Raymond Tan with generalized polyspite and wave and so on. If there's positive family history, if there are a lot of night seizures, nocturnal sleep seizures, partly because patients cannot be or unsure about how many seizures they have in the past. They may thought this is the first one, but in fact they have many more in the past. Or lastly, if the patient have cognitive impairment, then you know that there is already a brain damage which can predispose to seizure. Then it gives you a stronger reasons to consider starting medication more. So based on the definition in 2014, there is a very key statement here, which is 60% recurrence risk, which means that any of the patient, if you think that their chance of developing another seizures is 60% or higher, then you would want to start treatment. But what is 60% and how do we determine 60%? Based on this chart on the left y-axis, you will see that all the numbers here are percentage. So 0.4 means 40%, 0.6 means 60%. So if we draw a line of 1 year across, the only one that is likely to have 60% chance of having seizures is those with remote symptomatic causes. What does it mean? It means that if someone having an abnormal scan, for example, having an old stroke or having an old trauma or having an old brain injury or tumor, then the chance of them having another seizures will be 60% or higher. And therefore, in this case, you would want to start treatment. However, if someone having 2 seizures, then you would consider higher chance of recurrence as high as 60%. As you can see on the graph over the left here, the lower line is the percentage of recurrence in patient with first seizures. Even up to 3 years here and 6 years, the chance of them having another seizure is only about 40% for those with only 1 seizure. But if they have 2 seizures, the likelihood of having another seizure in 1 year go up to 60%. So the second rule is if their seizure recurred or if you have 2 or more seizures, then you would start treatments. The third rule is this. This chart is a bit interesting. If you read, this is the chance of having seizure recurrence after the first seizures. So after 1 year, there are 30% of them will have recurrent seizures. However, from 1 year all the way up to 5 years, this difference tells us how likely is the chance of having a seizure if someone have no seizure for 2 years. All right, so after 2 years until 5 years, there is only about 10% chance of having a seizure. What it means is that if someone has no seizure for 1 or 2 years, the likelihood of them having another seizures or seizure recurrence is only about 10%. So the risk is very low. Therefore, come back to the first seizures conclusion is that whenever you have an abnormal scan, abnormal EEG, positive family history, after second seizure, night seizure, or if cognitive impairment, then only you will start seizure medications. This is the guideline by AAN, American Association Academy of Neurology. There are only 2 key points here. The first point, starting treatment for first seizures, it will reduce seizure recurrence risk. However, starting treatment for first seizures will not improve quality of life. So if we explain this to the patients, most patients will prefer not to start treatment unless some patients are very concerned, they have severe injury in the first seizures, they have status epilepticus, or some of them dislocate their shoulders after the first seizures. Then they will consider more highly than the other patients to start antiepileptic drugs even after their first seizures, and even their scan and EEGs are normal. Second rules is how to choose the first AEDs. There are a few principles. The first principle is that we want to achieve seizure control but with minimal side effect. So this is the key terms. Effective, but not much side effect, tolerable, effective efficacy and tolerability. So what are the side effects that, or what are the key factors that we consider? In this guideline, this is in fact a very old guideline, but very useful because it looks at various factors. And I'll go through some of them one by one. And you can see that it's even cover insurance coverage for expensive medication and so on. Which I'll go through this later on using various cases so that we will understand this better. Okay, so using this guideline, we want monotherapy. Why monotherapy? Because monotherapy, firstly, it has less side effect. Combination of medications will increase the chance of having a side effect. Second, is simpler, it improves compliance. Patient is easier to remember. There's less or no potential drug-drug interactions, and it's actually cheaper. So first rule is monotherapy. And which drugs to choose? I have created four rules for you. The first rule is follow the evidence. This is the evidence comparing medications among various groups. And just look at the few examples here. First one, partial onset seizures, which we call focal seizure now. Focal seizure in adult, class 1, carbamazepine, levetiracetam, phenytoin, zonisamide. Okay. Second, elderly. Class 1, there are a few class 2 and 3 as well, is gabapentin and lamotrigine. Lamotrigine is in fact a medication with very few side effects. But interestingly, gabapentin has become one of the level A treatments for elderly as well. Third, absence seizures in children. The level A evidence is etosuximide and sodium valproate. We don't have etosuximide in Malaysia. You need a special import permit, which we have intended to do that for one patient. Otherwise, the treatment we use nowadays mainly is sodium valproate, and it is in children. So don't worry about childbearing, don't worry about teratogenicity, and don't worry about pregnancy. However, for juvenile myoclonic epilepsy, we have only two level D evidence, which is topiramate and sodium valproate. So if you don't use valproate, you may consider topiramate, but topiramate also have teratogenicity risk. So we go to the next one, which is lamotrigine and levetiracetam. So this is the rule number 1, get the evidence and follow the evidence. Rules number 2, follow the seizure types. Just focus on those with yellow bar. Yellow bar cover a lot of others generalized seizures types, mainly myoclonic seizures and absence seizures. This is generalized tonic-clonic seizure, GTCS. CPS is complex partial seizure, or what we call as focal seizure with impaired awareness, FIAS. SPS is simple partial seizures in the past. We call focal seizure with focal aware seizures. So what are the medications which is useful for generalized seizure types? Firstly, sodium valproate, yellow bar. It is suitable for all types, sodium valproate. Lamotrigine is supposed to be suitable for all as well, but in some with myoclonic seizures, it may aggravate up to 30%. The others are the newer medication, including topiramate, zonisamide, as well as levetiracetam. So this becomes some of the options when you are treating especially generalized seizures. Third, follow the guideline. This is Malaysian Consensus Guideline. As I mentioned, you can download from our neurology MSN website. In this guideline, you can see that for focal seizure, these are the monotherapy that we have recommended. Let me go through the list again. Carbamazepine, lamotrigine, levetiracetam, oxcarbazepine, which is trilaptol, sodium valproate, and zonisamide. For myoclonic seizures, it's still sodium valproate, followed by levetiracetam and topiramate. You see that lamotrigine is not listed here, partly because, as I mentioned, it has 30% seizure aggravations, but yet it is still effective in the others 50 to 60%. So this can still be considered, but not in the list. And the last rule is keep it simple. If you can't remember any of the names above, then just remember generalized epilepsy, sodium valproate. But if not, then we consider lamotrigine or levetiracetam. Focal epilepsy, we consider carbamazepine. But if carbamazepine is not working or you have concern or HLA-B positive, then you can use lamotrigine, levetiracetam, and zonisamide. These are some of the recommendations, and we will go through the reasons why based on cases later on. Okay, so can I have the pool now? So this is for a 16-year-old boy with generalized seizures. Remember, this is a boy, given phenytoin and developed early morning myoclonic jerks. EEG show generalized polyspike and wave complexes. So what diagnosis is this patient has? Juvenile, firstly, the onset is juvenile age. Secondly, get myoclonic seizures with polyspike and wave. So the diagnosis is juvenile myoclonic epilepsy. So which AED would you consider? Valproate, carbamazepine, lamotrigine, levetiracetam, based on the 4 rules just now, the evidence, the seizure types, the okay, wow, so fast. So the guidelines as well as the simple rules. So based on the simple rules, valproate is good, and this is a boy. We have no other concern, and we can straight away say, oh, valproate is the best. Juvenile myoclonic epilepsy is a syndrome, which is a generalized epilepsy syndrome. Seizure is easily controlled. However, a lot of them has recurrence. So do we want to start treatment? Yes. For boy, it's sodium valproate. For female, we have to consider others. And don't use carbamazepine and phenytoin because they can aggravate myoclonic seizures. And remember, as I mentioned just now, lamotrigine was not listed in the guidelines because it has also 30% chance of aggravations but can be used. When we talk about how long do we start treatments or continue the treatment even if the seizure is controlled, usually I told the patient in a more positive way. I said that maybe after 2 years, if you have no seizure, you can consider cutting down if you are not facing a severe stress like exam or job requirement. However, the chance of recurrence is high, as high as 70%. So some patients, or in fact, most of my patients with JME, they are on treatments lifelong because they will have on and off seizures when they cut down their dose, when they have late sleep, when they have exam, when they have a lot of works and stress or miss their dose, they will have recurrence of seizures. How about girls? So this is ABCDE, and I didn't create a pool for this. But the key thing is we want to avoid valproate, as Surini has mentioned. So because of that, I won't go through the details, but I'll just quickly discuss how about the others. So this one also Surini has already stated, and there's a follow-up study up to 6 years old about the low IQ. But remember, this is dose dependent. Teratogenicity, I just want to mention about carbamazepine. Carbamazepine is in between. Over here is about 3%. This is the North American guideline. And this one, the risk is about 2.3%. Just remember, as Serene mentioned, 2 to 2.5% malformation risk is present in general population. Anyone, any women, any pregnant women without any diseases, the chance is 2.5%. In Malaysia, why we still use carbamazepine despite a D recommendation is because in Malaysia, our carbamazepine dose that we use are usually very small. We use 100 milligram BD, 200 milligram BD, as high as 400 milligram a day. We seldom go to 600, 800, or even 1,000. Partly because Malaysian, they don't tolerate carbamazepine that well. So as compared to Caucasians, they use as high as 1,000, 1,200, or 1,400 milligram a day. Whereas in Malaysia, in Asian, we don't use that high. And therefore, in certain population, the teratogenicity risk for carbamazepine is in fact not as high as sodium valproate and phenytoin. And because of that, this is still one of the options we use even in a pregnant lady. But we may need to monitor their drug level. So the yellow one, I just want to highlight topiramate. Topiramate when it first came out, there isn't much information, but later on we found out that even in our patients, the baby develop cleft palate, there are many other malformations, and now we also try to avoid topiramate in pregnant mother. So just remember, among all the newer medication, topiramate is the one that we want to avoid. So this chart, Serini also has mentioned, and I just want to talk about the dose dependency. Higher the dose, higher the risk of teratogenicity. So therefore, if someone who is only on small dose of medications, then we have a few options if they want to get pregnant. First, if they have been seizure-free for 2 years, even in JME, and wanted to get pregnant, I would still consider a trial of withdrawal, either cutting down or stop the medication, partly because they has been seizure-free for 2 years, and we can consider whether they can maintain the seizure freedom despite not on any medication. Second, if the dose is high, then we should consider other AEDs prior to the pregnancy. If it's already pregnant, then nothing much can be done. Thirdly, if the dose is very small, like on epilim of 200 BD, which is only 400 milligram a day, you can see that the risk of the teratogenicity risk of 400 milligram a day is as similar or to the higher dose of lamotrigine. So it doesn't really affect much. Thirdly, also because of the duration of pregnancy, if someone already getting pregnant and in the first trimester, the risk of malformations is already there and is over. So there is no point changing the medications when they are already in their end of first trimester or going to the second trimester. So this one, Serini has covered. I will skip this just to remember that although there is a notice by NPRA, which is National Pharmaceutical Regulation Agency, we will still use sodium valproate in female according to individual preference and cases. Okay, so in a girl, valproate is the first line. Sometimes it's much useful as I have a patient which I switched to lamotrigine. Oh, sorry, it's not the pool yet. Not the pool yet. So thank you. So valproate, I have a patient who has frequent injury after I switched to lamotrigine, then Keppra, and Keppra she developed irritability and the myoclonic jerks is just not controlled. She will come back with bruises on the face, bruises on the leg because she has injury, and I have no choice but to switch it back to sodium valproate, and it works, and patient is well. Another options which I want to try is sonizumab or topiramate. That one also cause side effect in that patient. Okay, so carbamazepine and phenytoin can aggravate myoclonic jerks. Don't use. Lamotrigine may aggravate myoclonic jerks as well. And the problem of using lamotrigine in pregnancy is because of the interactions with the hormones and in pregnancy. Levetiracetam is in fact a good choice. In the past, it's very expensive, but now we have generic drugs and is being used more and more, even in government hospital up to district level. But I realized that levetiracetam is not present in many primary care or KK or clinic kesehatan, or they have specific quota. So not everyone can be given levetiracetam. Lamotrigine level has been mentioned, so I will not go through the details, just to mention that lamotrigine level can be checked in private lab. So in government hospitals, don't offer lamotrigine level TDM, but can be checked in private lab. It costs about 200 ringgit each year. Just remember, check them in second trimester and third trimester if you want to make sure the seizure control or the level is therapeutics. Women's, the one that in addition is polycystic ovarian syndrome, we just need to make sure it's very common in normal population, but it's higher in those with sodium valproate. And if you can, try to avoid sodium valproate, especially in obese lady. Okay, so now we come to the third question, which we need the pool here. This is focal epilepsy. As I covered, first seizure, generalized seizures, and now we come to focal seizures. So this is the third part. Okay, so based on Dr. Khoo semiology lecture, patient has oral automatism and left dystonia. Where is the seizure from? Okay, answer is temporal lobe. And where is it? Is it left or right? Answer is right side because the patient have left dystonia. Okay, this is a repeat of what Khoo has mentioned just now. So the pool, can we have the pool now or cannot? So, okay, great. So which one do you consider? There are so many of them. Huh? Which one? Or some of them, if you don't know what it is, then you don't have to take. Which AED would you consider based on the simple rules, evidence, guideline, seizure type, and simple rules? Okay. Okay, can we have the answer now? Oh, wow. 67% follow the rules. All right. Let's go to some of the other drugs. In fact, all of them can be used, but carbamazepine is the first one we consider. The others, the perampanel and nicosamides, they are in fact the newer medications. Okay. So this is a guideline, carbamazepine and phenytoin, but we don't use phenytoin nowadays because of a lot of side effects, unless in a very refractory patients, or some people ask me, if I start IV phenytoin for status epilepticus, what should I use next? Usually in the past, I will continue phenytoin, change IV to oral. But nowadays, I will switch to carbamazepine if I have checked their HLA-B1502 level. Okay, so what happened is someone admitted of status, given IV phenytoin, I'll continue with oral phenytoin, but switch to carbamazepine later. As we know that not everyone responds to medication, especially focal seizures. The response rate is only about 60% and 40% will not respond, and we need many other newer medications, and therefore we need to know them. So in this case, a lot of them are preferred carbamazepine. In fact, in our cohort, we use carbamazepine as well. But the seizure freedom rate, if we expect, is about 40 to 50%, as is in fact, there are half of them will not be seizure free. So because of that, we want to consider other agents, and we need to know that. But prior to carbamazepine, in the old days, without HLA-1502, I'll just say this. I'm going to start this carbamazepine. There is a chance in 1 in 1,000 or 0.1% that you may develop skin reactions or allergic reactions. If you have rash, if you have blister, if you have mouth ulcer, you stop the medication immediately. This is what I'll do in the past. Or in some center without the HLA screening, we also can do that. But now we have a screening, which is HLA-B1502, which was reported in Taiwan. And Taiwan realized that the chance of having Steven Johnson with HLA-B1502 is much higher. We in fact replicate this among our Asian group. This is in Thai, in Indians, Malaysian Indians, in Vietnam, in Malaysia, and then in Indonesia, in Myanmar. You can see that we have done a lot on the carbamazepine HLA work among the Asians. And in fact, population having HLA-B1502 belongs to the South China and South Asian groups, including Taiwan, South China, Thai, Vietnam, Myanmar, Indonesia, Malaysia. and Singapore, of course. Not in the North China, not much in India, and don't worry in Japan and Caucasians. So, however, not everyone with positive HLA-B1502 will have Stevens-Johnson. The risk is about 1 in 20. So let's say someone is tested positive, there is 5% chance of them develop Stevens-Johnson, but it's high, partly because if someone develops Stevens-Johnson, it can be very severe, it can affect their eyes, it can even affect their skins with long-term sequelae, all right? So it is very high. So tested positive, we would not give carbamazepine. Tested negative, the risk is small, and therefore we can still give, but yet there is still a small, very, very small risk. Even someone with tested negative for 1502, they can still develop Stevens-Johnson. In our cohort, 1/3, about 2 out of 8, sorry, 1/4, 25% of all people, of all patients with Stevens-Johnson secondary to carbamazepine, 25%, doesn't have 1502. So it can still happen. Just remind the patients to stop whenever they develop the rash. So if they fail to respond to carbamazepine, what is next? We can consider all the newer medication. But this chart told you that none of them are really much better than carbamazepine. Okay, so on the left chart is 50% seizure reduction. On the right chart is seizure freedom. And they are all compared to carbamazepine. This is the enzyme-inducing group in the upper half and the non-enzyme-inducing group in the lower half. It just says that they are just slightly or similar in terms of efficacy to carbamazepine. However, if the seizure is very frequent, very severe, I will consider topiramate first, partly because it is very effective. However, topiramate has a lot of side effects. Patient cannot tolerate, patient have word finding difficulties. If the patient is milder, having less frequent seizure, like once a month or once every 2 months, then we can consider lamotrigine and zonisamide, which is less effective, but also less side effect. Tolerability is better. In the past, we don't use levetiracetam that often because of the cost. But now, if we are using generic, then this can be one of the good choice in treating focal epilepsy, not responding or not suitable for carbamazepine. Drug-drug interaction, we talk about oral contraceptions just now. There is an interactions, so we should avoid all the enzyme inducers, especially carbamazepine. If someone is on oral contraceptions, they may also affect the lamotrigine level, and the lamotrigine level may drop because of the estrogen as well. How about COVID treatment? We are now having COVID treatments. There is, in fact, drug-drug interactions between COVID treatments, especially chloroquines and all the antiviral with the enzyme inducers like carbamazepine. So if an epilepsy patient develop COVID, then we should consider whether to switch their antiepileptic drugs or to levetiracetam or topiramate, or consider drug-drug interactions during the treatments. In elderly, we try to look into one of the important side effects, which is osteoporosis, especially enzyme-inducing drugs. And therefore, in elderly, we should consider doing bone mineral density as well as supplement them with vitamin D if possible. So these are the newer anti-epileptic drugs. In the past, we have only old generation and new generation, but now we have first, second, and third generation. Third generations are those come in the last 10 years, including perampanel and lacosamide. But lacosamide is not distributed in Malaysia anymore because we don't have a distributing company. However, we still can import, like my hospital, we still have an individual import permit for those on lacosamide. Why are new medications considered? They are not much better in efficacy. It's about the same. They are not much better in side effects. Some are better, some are poorer. Like perampanel can have severe drowsiness and sleepiness. But if you are giving them during sleep or before sleep, then this side effect can be manageable. However, what we are trying to do is we are trying to find medications with new mechanism of actions or new tolerability so that it can help the patients who are refractory to the older medications. So we can keep trying. And this is a very long chart just to highlight that the newer medications, a lot of them has different mechanism of actions or modified in their mechanism of actions. So I summarize all again. Today I cover about first seizures and choosing first line antiepileptic drugs, especially on the principles. And I only introduce you on some newer AEDs so that if the patient is not responsive to medications, refer to us to try some new medications. And if it's not responsive to drugs, we should consider surgery later on, which Sugandhi will talk about it. So this is a chart again. Think about it. If you are in the general medicine, if you are in the primary care, if you are in the clinic kesihatan or GP or medical students, don't refer to neurology straight away. Consider doing the diagnosis, get the investigations, start the initial management, and then consult. Thank you very much.
Thank you very much, Prof. Lim, for your lecture. I think it was very, very comprehensive. You touched on the types of suitable treatment for focal, generalized epilepsy. You talked a bit on the treatment for older patients and women. And we've got a few questions in the chat group.
You want me to answer? Oh,
yeah,
okay.
if you
First one,
maybe
10 years
we can
old
have.
girl.
Yeah.
10 years old girl with absence seizures, mean most likely childhood absence. Their absence may go away, it may go into remissions when they grow older, before they get married, before they get pregnant. So I will still use valproate, but if they have other side effects like obesity and so on, we can still manage them accordingly. Epilim or sodium valproate related obesity, I don't straight away stop sodium valproate. I will ask them to exercise, control their diets, have a healthy lifestyle first, and see whether it helps or not. Edoxasamide is not available in Malaysia. If you need that, we need a special import permit. The case I mentioned just now is a young man, 15 years old, having juvenile absence status. His absence seizure is every 10 minutes, there will be one seizure, but he will not be aware. Some of the seizures we record in EEG, he will just blank stare for a while and then he'll be okay and he can continue studying, but no drugs, none, no available drugs in Malaysia can control that seizures, and that's why we import edoxasamide. But at the end, he somehow, somehow his seizure was controlled before the edoxasamide was imported. Second question from Adrian, JME and focal epilepsy, do we wait for second occurrence of seizures as in the first unprovoked seizures? Answer is yes. A lot of times, JME, if the EEG is normal and scan is also normal, you are unsure because JME, most often the EEG will be abnormal. All right, so myoclonic seizures, abnormal EEG, I will start straight away. Or myoclonic seizures with family history, I will start medication straight away. But if there is just myoclonic seizure alone, without other factors, we may still wait, partly because it's only a few jerks in the morning. They have no generalized tonic-clonic seizures yet. So we can discuss with the patients, as Sereni mentioned, counsel, talk, and then we will wait and see. Moshida Ainun asks, if we need to change AED, is there any dose equivalence? We have to start with lowest dose. Answer is yes. There is very difficult to find equivalent dose, except carbamazepine and oxcarbazepine. We can use dose to dose exchange. Otherwise, lamotrigine to levetiracetam or carbamazepine to levetiracetam. we will never know what is the equivalent dose. So we always start with the lowest dose and titrate. So the rules is keep the first one, push the second one up until good maintenance dose, then only cut down the first one. This is what I usually do. If you look at the video I'm showing now, keep the first one, push up the second one, then only cut down the first one. Dr. Abdul Hanif, if provoked seizures due to infections or any other brain insults, would you continue AEDs? Answer is, if you think the insults is going to be continuous, like an encephalitis with persistent or permanent brain damage, then we will need to continue antiepileptic drugs. But if it's just a meningitis, which has recovered and there is no brain damage, then the chance of recurrence is actually low, and you think that insult is over, then you may want to wait. So another example, a severe brain injury with intracranial bleed. It will cause scarring and hemosiderin depositions in the brain, likely to have recurrent seizures, and therefore we continue. Alvin Oliver, thank you. Just a simple question. We decided to start AED in patient for seizures. How long do we keep the patients on AED? Because consider the rules is 2 years. As I usually talk to my patients, seizure free for 2 years. Then after that, we can consider reducing or stopping the medications. What is the protocol of stopping AED in post-stroke epilepsy? Answer is that I usually don't stop, although we still follow the 2 years seizure remission rules, partly because, okay, stroke, if it's small, like lacunar stroke, then the chance of recurrence or even causing a seizure is lower. Sometimes we are happy or feel safer to stop after no seizures for 2 years. But if it's a very big stroke, a cortical stroke like MCA stroke, then we wouldn't want to stop the AEDs because the chance of recurrence is high. Thank you very much. Yes.